Good evening. Welcome to another episode of Fresh Natural Live. We are live, fresh and natural. Here on a Monday evening, it's October 3rd, 2022, and we're going to be talking about atrial fibrillation. I was watching a little bit of football this weekend, and I found out that a former star of the Houston Texans, J.J. Watt, was diagnosed with atrial fibrillation. And I started thinking about that, and I said, well, a number of athletes in the past have been diagnosed with this arrhythmia. We commonly see it in older adults with chronic heart disease, but it can be seen in athletes. And we're going to talk about that in a little bit of detail. I'm going to talk to you about atrial fibrillation and give you some insight. It's the most common arrhythmia that we see in cardiology, and I think you should know a little bit about it. So stay tuned. This is going to be a great show tonight. Okay, so you caught me here looking at my screen. Welcome back. We're going to be talking about atrial fibrillation today. And as I said, I was watching football this Sunday, and the defensive lineman, J.J. Watt with the Arizona Cardinals, it was reported that he was diagnosed with atrial fibrillation. Apparently, this information was leaked, but the part of the story I know is that he had been feeling bad at practice one day. He was feeling weak and tired and underwent an evaluation. And apparently an EKG was done. He was found to be in atrial fibrillation. He was taken to a hospital seen by cardiologists and underwent treatment for the atrial fibrillation. And I want to talk about what that treatment was, at least the reported treatment. But before I do that, I want to talk about atrial fibrillation. Atrial fibrillation is a very common arrhythmia. As an electrophysiologist, I've dealt with hundreds, thousands of patients with atrial fibrillation. I see it a lot in my patients today. And it's an arrhythmia that we have to manage very carefully. So I'm going to get started on that. Let's talk about atrial fibrillation. We're also going to look at one particular procedure that's used to treat atrial fibrillation called cardioversion. But before we get on to this, I want you to give us the thumbs up, show us some love. If you hadn't had a chance to subscribe to this channel, please do so and share it. So thumbs up, subscribe, and share. Hello, everyone. Hello, Bernadette. Okay. Hey, Dr. M, we were just discussing you in 10 Million Black Vegan Women Group Breakout. Okay, wonderful. I'd like to hear what that's about. William Bespoke, Bibbs. So welcome to the show, guys. Let's talk about atrial fibrillation. I have a few slides I'm going to share with you. Atrial fibrillation, as this slide implies, often can require the use of lots of medical therapy. Here's a nice schematic that shows an EKG tracing. Now, many of you who don't know what EKG tracings look like, I'm going to walk you through this. Above, you can see here's a normal tracing, and below here's a tracing with atrial fibrillation. If you look here, this little letter with an arrow is called a P. We call this the P wave. And the names are not that important. This little bump, you see a bump, and you see a spike, and you see a hump. Bump, spike, hump, bump, spike, hump. The bump, spike, and hump, that cluster of three things represents an electrical cycle for one heartbeat. So the bump is the electrical signal that comes from that passes through the upper chamber. The heart has four chambers, has two upper and two lower. The upper chambers are called atria. The lower chambers are called ventricles. The upper chambers, which are atria, you have the right atrium and the left atrium. These are chambers with fairly thin walls, so have a thin amount of muscle in it. So when electrical tissue passes through the thin electrical muscle of the upper chamber, it doesn't give us much of a signal. So you see a smaller bump. But then when the electrical wavefront passes through the lower chambers, the lower right and left ventricles, they're much larger chambers with thicker muscle walls. And so they give a larger electrical signal. So you see a larger spike here. And this hump represents what we call repolarization. When an electrical signal passes through tissue, the tissue, which starts off polarized in one direction, is polarized in the other direction. And it has to flip back and be polarized in the original direction in order for the electrical current to pass back through. And this polarization is based on cell by cell. What we're looking at here is the summation of electrical signals and the summation of polarization and repolarization that passes through all of the heart muscle tissue. Now, the repolarization of P wave is buried here in this activation. So that's why you don't see a small little hump representing repolarization of upper chambers, but this is repolarization of lower chamber. So electrical signal passes through the upper chamber, a bump, lower chamber, spike, hump, bump, spike, hump, and so on and so forth. So that's a normal rhythm for normal electrical signal, etc. However, something can go wrong in the heart muscle tissue, particularly in the upper chambers, where you go into what's called atrial fibrillation. And so that's what we see here. Notice instead of this small bump, you see these little things here. See this little erratic squiggles. They're not the squiggles. That's atrial fibrillation. And notice how the spikes, this is the electrical activity in the lower chamber, how they're organized and they're farther apart. Because when the electrical signal goes through the normal conduction pathways, conduction to the lower chamber is normal. When it goes through abnormal pathways, or there's an abnormal circuitry that's controlling the electrical signals in the upper chamber, then the conduction to the lower chamber is more erratic. And the conduction passing through from the upper to lower, through the conduction tissue from the upper to lower chamber is much faster, and it bombards the lower chamber so that the lower chamber beats faster. So that's why these spikes are much closer together. So this down here is beating anywhere from 3 to 4 times faster than the heartbeat up here. So you see you have a atrial fibrillation is faster heartbeat and more erratic. So if any of you have had atrial fibrillation and you feel your heart palpitating, it may be palpitating irregularly, and therefore you're getting a rapid, irregular, and erratic heartbeat, and that's typical of atrial fibrillation. Now, I'm not going to bore you with too much what we call pathophysiology, but I think it's worth getting into a little bit of this, because if you look at this is a CT scan of the back of the left atrium, which is an area that we put a lot of attention to when we're dealing with atrial fibrillation. And the left atrium can have these areas of rapid focal signals. And you can get a lot of these rapid signals. And I say rapid focal signals, these are excited tissue. And so you may have two where you have multifocal atrial tachycardia. You may have 3 or 4, but you can have infinitely many erratic sites. And these infinitely many erratic sites are sending little signals from different locations. And they're usually like reentry circuits that are coming from different locations that's causing this erratic and irregular, rapid, erratic and irregular conduction from the upper chamber to the lower chamber. So that's what we're dealing with, is sort of electrical chaos in the upper chamber. So the upper chamber goes from beating normally and synchronized to beating erratically. And so that's what we're dealing with here. So here's another schematic, sinus rhythm. It's a little more of a cartoon, but it shows the erratic nature that converts. This person is clutching their chest. Frequently, when you go into atrial fibrillation, the symptoms you feel is fatigue, chest pain, sometimes dizziness. And the reason for that is that your circulation is compromised. Usually, the upper chambers, when they contract, they eject blood from the upper chamber to the lower chamber, and the lower chambers eject blood out. In the case of the right ventricle, the tract ejects it out to the lungs where you get oxygen, and the left chamber the lower ventricle on the left ejects out to the systemic circulation where the body gets oxygen and nourishment. But if the circulation, the contribution of circulation from the upper chambers is taken away, in young, healthy people, that can be anywhere from 25 to 30%, maybe 40%. And the older people can be 50, 60, 70% of their total circulation contribution. So although younger people can be very symptomatic, feel fatigue, etc., older people can go into heart failure, can be totally wiped out, can have, chest discomfort, fatigue, dizziness. And so they can have severe symptoms with atrial fibrillation, and we have to get them out of atrial fibrillation pretty rapidly. So it can cause symptoms. The other thing is that it predisposes to blood clots. And this diagram is showing a schematic of a blood clot, because when the upper chambers are beating erratically, then blood sloshes around, and because it's not flowing in a hemodynamic or fluid dynamic way, it can become stagnated inside certain corners of the upper chamber called the atrial appendage. And that's where we look to find clots. And oftentimes you'll find clots in the left atrial appendage. That's a little pocket inside the atrium where we can find clots. And these clots can break off and go to different parts of the body. Sometimes it can cause strokes and cause heart attacks and other other problems. So how do we treat atrial fibrillation? Well, we try to get them out of atrial fibrillation, and we'll talk about that in a minute. If we're not able to get them out of atrial fibrillation, at the very least, we want to control the heart rate. I showed you not only is the heart beating erratically, but it's beating rapidly. So if we can't immediately convert the rhythm from atrial fibrillation to a normal rhythm, we'll at least try to give medication to slow the heart down. And then some of the long-term management includes preventing stroke. And so frequently someone with atrial fibrillation will be started on a blood thinner, and quote unquote blood thinner. They're really anticoagulants. Typically, historically, warfarin was the Coumadin, as people know it as. It was an anticoagulant, but there's some other agents that are used as anticoagulants commonly now. And you don't have to get the frequent blood draws to check your international anticoagulation ratio. But how do we determine who needs a blood thinner or not? Well, it depends on whether you have other illnesses. So, for instance, if you're a young, healthy person, you don't have high blood pressure, and you're physically fit, you don't have congestive heart failure, you never had a stroke before, you don't have vascular disease, et cetera, then you may have what we call a low CHA2DS2-VASc score. There's a scoring system we have where we give you points. And if you see here, if someone has congestive heart failure, they get 1 point. If hypertension, they have another point. If they're 75 years older, they have 2 points. If they have diabetes, they have 1 point. If they've had a stroke or TIA, a thromboembolism of any kind, or a blood clot, if you will, they get 2 points. If they have a history of vascular disease, so ischemia in the heart or peripheral vascular disease, they get a point. If they're age 65 to 74, they get a point. And if they're female gender, they get a point. So you can add these points up in the sense that, let's say you are an 80-year-old female with hypertension. If you're 80 years old, that's 2 points. Female gender is 1 point. That's 3 plus hypertension. That gives you 4 points on the CHA2DS2-VASc score. And looking at this scale, you consider anticoagulation. Really, in this situation, some people say consider anticoagulation. That's a CHA2DS2-VASc score 0. So anybody with atrial fibrillation, you consider anticoagulation. But typically, we don't treat, or at least I don't treat someone with chronic anticoagulation if they have a 0 CHA2DS2-VASc score. If they're on any of these risk factors, I tend not to treat them. And I think most of my colleagues are the same. Now, there may be some other considerations that, may bring you into that. These are probably extenuating circumstances. When you get to CHA2DS2-VASc score 2, I consider that borderline. It depends on the patient, depends on what they're doing lifestyle-wise. If I can reverse some of these conditions with lifestyles, for instance, if you're 75 or older, you have a 2, then heck, that's already a 2. So, you can't reverse the age. With female gender who's 65 to 74, that's 2. So there's some things cannot be reversed. However, what if this person had hypertension, heart failure, and diabetes, and we have a nutritional detox diet, and they're following that, and they're exercising and doing extremely well, and maybe they've undergone a procedure for AFib ablation or not, but we do extensive monitoring. You don't see any AFib after you've done this aggressive lifestyle monitoring program, and they stick with it, then we'll have a conversation. If it's their desire to come off anticoagulant, I'll strongly consider it. As the number gets higher, it becomes more difficult. But then as the number gets higher, you have more of these components that are potentially reversible. So someone may start off with a CHA2DS2-VASc score of 4, but if they do things to reverse diabetes, reverse the hypertension, lifestyle wise, and bring yourself down to 2, 2.5, or whatever, then we may consider taking that person off anticoagulation. Again, it's all done on an individual basis, in my perspective, and it's just a matter of seeing what the person's able and willing to do. Here's a slide that talks about the variation. So here you have atrial fibrillation with a fast heart rate. We call it rapid ventricular response. So you may hear people in the medical field, AFib and RVR. RVR is a rapid ventricular response. And so you have AFib there, and then you have rate controlled AFib. So you may give them a medication like a beta blocker or a certain type of calcium channel blockers that control the conduction of the electrical signals from the upper to the lower chamber. So then there's still an atrial fibrillation, in which case they're still at risk for a stroke. However, you control the heart rate. Now, a fast heart rate can put you into heart failure. So can a heart and atrial fib with a normal control rate. However, the faster heart rate has a greater propensity to contributing to the production of heart failure. So you want to control the rate at the very least. And then ultimately, you want to get them into sinus rhythm and keep them in sinus rhythm. The considerations and management is outlined here. For rate control is beta blockers, rapamyl, digoxin, AV junction ablation. When I was an EP fellow, we were doing some of these AV junction ablation. We put a catheter in the electrical area between the upper and the lower chamber, very near the bundle of His. We'll put a burn there, and we'll prevent the conduction from the upper and lower chamber and plant a pacemaker. And that was the ultimate way of controlling the rate, because the patient either did not tolerate the medications or the medication were not effective at controlling the rate. So we would do this ablation. Digoxin, rapamyl, digoxin, beta blockers are also useful. Stroke prevention, anticoagulation, as I mentioned. Now, there are new therapies where you can occlude the atrial appendage. Remember, I said the blood clots can form in the little pockets of the upper chamber called the appendage. And so in these little pockets is where you have the greatest propensity for clot formation and therefore stroke. And so several studies have shown using different occlusion devices that close off this little pocket to prevent the clot from being dislodged have been found to be helpful. And therefore, these patients have benefited from that and have been able to come off anticoagulation. At least some studies have shown them to be as beneficial in preventing stroke. There's also a surgical procedure, a minor surgical procedure where you can clip the atrial appendage, just get rid of it altogether. And that also has been shown to be helpful in reducing stroke. And so there is an alternative to anticoagulation as well. Treatment of risk factors. Now, really, the literature has shown the most effective, benefit for AFib is diet and exercise. So you want to treat the risk factors aggressively with lifestyle. Control the high blood pressure, hyperlipidemia. All these things in this list here can be effectively treated with aggressive lifestyle measures. So you can really wipe out this list and really change your overall prognosis with just aggressive lifestyle therapy. And so that's one thing that I encourage people to do from the standpoint of controlling the AFib is to have aggressive lifestyle therapy. Then long-term strategy, reducing symptoms, maintain sinus rhythm, antiarrhythmic medication. There's also catheter ablation. There's also a surgical maze procedure. I don't see many patients undergoing this procedure very much. I remember as a cardiology fellow before they came up with before we were doing AFib ablations with a catheter, there's a surgeon that would do this procedure. He would open up the chest and take the atrium out and put these scars in the heart and put the atrium back together, and that'd be the maze procedure to keep the person out of sinus rhythm. I think there was a fairly high incidence of needing pacemakers after this procedure. But more patients are getting catheter ablations. About 20 plus years ago, I was doing catheter ablations for AFib, and I'll share a little bit about how we do that in just a minute. Well, actually, this is my last slide. So let me just kind of use this other diagram. Here you see, and this is what we call a 3D map of the atrium. You're looking from the posterior side of the heart, and actually, yeah, you're looking posteriorly, but you have the left superior pulmonary vein, left inferior pulmonary vein, right superior pulmonary vein, and right inferior pulmonary vein. So this is a posterior view. And essentially, you see the opening here. This is where the left pulmonary vein opens into the left atrium and the right into here, and so on. When I was doing them, I would put a basket catheter here, and I would find the neck, the ostium of this vein, and I would find the actual electrical signals and burn those individual signals. I would isolate by burning those signals. I do the same thing here, and I go over here and over there. They do it a little bit differently now. They will put a wide circumferential burn. This person isolated both of these veins in totality, and so you have a wide burn isolation here. And that's found to be effective. Now they'll put some burns in the atrium as well. And what that does, that prevents the electrical signals coming from the pulmonary veins into the left atrium. The problem is that atrial fibrillation is not an isolated electrical abnormality. Of all my patients, I ablated with what we call supraventricular tachycardia with a mechanism of avian-overventricular tachycardia. Had 100% success rate. There's one pathway, you're going to ablate that pathway, it's done. Wolf Parkinson White, similarly, you ablate that pathway, it's done. Atrial flutter, the typical atrial flutter, in the vast majority of cases, you ablate that critical pathway, and you're done with atrial flutter. With atrial fibrillation, is a little bit different because a lot of atrial fibrillation is not just due to increased excitation from these veins, but it's just due to the fact that because of increased inflammation and increased oxidative stress, you get scarring and you get destruction of the electrical properties of the atrium. And so there's a wear and tear of the atrium. And because there's wear and tear, the electrical signals doesn't transfer normally, and you get disruption of electrical signal, and then that sets you up for atrial arrhythmias. And so you can do the ablations, but most people require 2 ablations. And even after 2 ablations, many people require medications. And if they don't have aggressive lifestyle changes, you have a significant failure even after 2 ablations and medications. And so essentially, there's a high recurrence rate, large, not because the ablation procedures are not good, it's just because the overall cause of atrial fibrillation is more of a systemic insult on the heart myocardium, particularly the atrium. So here's a diagram showing this procedure, and I used to scrub up, and you place these catheters, have a CT scan mapping, have these complex electrical signals that you're observing, and you're manipulating your catheter and mapping and putting your burns into the left atrium. A fairly complex procedure, but it's commonly done, and it can be done fairly effectively and safely. So what I've done is given you an overview of atrial fibrillation, and the key story was an athlete, J.G. Watt, who had atrial fibrillation. Many of you may say, well, why would an athlete have atrial fibrillation? These are young, healthy individuals. Actually, there are many athletes, well, I say many, a number of athletes over the years have been diagnosed with atrial fibrillation. Some required cardioversion, some required ablation therapy. And so athletes are humans too. They seem like they're superhuman, but they're human. And as I said, atrial fibrillation is a systemic disorder. And so if you look at, okay, why does someone go into atrial fibrillation? Well, increased inflammation, increased oxidative stress. Well, what causes inflammation, oxidative stress? Well, exercise can do that. But your diet, I mean, the foods you consume, if you're consuming processed sugars and processed carbohydrates, you're consuming excess animal protein that triggers inflammation, you're consuming, saturated fats. All of these things contribute to increased inflammation, oxidative stress. And just like they can cause any other disease, they can cause atrial fibrillation. So even though you're a young, healthy athlete and you exercise, and those are all positive things, if you're consuming the standard American diet, we know that many athletes who've consumed the standard American diet who've had problems. And so atrial fibrillation isn't significantly different in that regard. So J.J. Watt, as I said, was feeling symptoms of fatigue during practice, wiped out. And J.J. Watt, from what I recall, when he was a Texan, was always in shape. Always worked out, kept himself in tip-top shape. He wasn't the type of individual who, as best I can tell, slacked off from working out and coming to training camp in shape. Very dedicated to his field. So he felt fatigue and was then diagnosed with atrial fibrillation. So the question is, why did he feel fatigue? As I said before, the upper chambers of atria contribute to your cardiac output. It contributes to your circulation. So if his atria goes from beating like this and all of a sudden start fibrillating, then that compromises the flow of blood within the heart and therefore the flow of blood from the heart. So you can imagine someone with increased demand of cardiac output. He's running, he's jumping, he's going against offensive linemen. They're doing lots of agility drills in practice. So he needs a very high cardiac output. It's very demanding sport. So if he has 10%, 15%, 25% drop in cardiac output, he's going to notice that. And so that's essentially what I think happened. And as a result, he was evaluated and fortunately found the cause and underwent a cardioversion. So what I want to do is share with you a couple of videos that talked about a cardioversion. So many of you may not have seen a cardioversion. Here are a couple of visions. One, the first one is just a few minutes, and it talks about the cardioversion of atrial fibrillation. So hold on one second and we'll take a look at this.
Emergency department management of atrial fibrillation is changing. In the past, the emphasis has been on simply controlling the patient's heart rate. Today, the emphasis is on not just controlling the ventricular rate, but also on converting the rhythm from atrial fibrillation back to normal sinus. This applies not just to unstable patients, but also to stable patients. Most patients who are converted from atrial fibrillation to normal sinus rhythm can be discharged from the hospital. For elective ED cardioversion, the patient episode of atrial fibrillation must be less than 48 hours duration, or the patient must be on some form of ongoing anticoagulation. To begin the process, the patient is placed on a cardiac monitor and an intravenous access obtained, just as with any other cardiac patient. The discharge is delivered through stick-on pads in most patients, although the normal paddles can be used in patients if these pads are not available or do not fit onto your cardiac monitor defibrillator system. Pads are placed generally in the anterior portion of the chest over the sternum, usually a little bit to the right, and the second pad is placed in the posterior part of the chest, just a little bit to the left of the midline, at about the level of the heart. The synchronized function on the monitor defibrillator is activated and usually indicated by a small mark over the QRS complex. This allows the system to determine when the shock should be delivered so it is not administered during the vulnerable part of the QRS complex, which might result in the production of ventricular fibrillation. The patient is sedated with any combination of procedural sedation agents. In many instances, propofol is selected, mainly because it is rapid acting, produces deep sedation, and some sense of amnesia for the events. Once the patient is sedated, the monitor is checked to make sure it is in the synchronized mode and sensing. It is charged to 200 joules. There is no need to start at lower energy levels and titrate up. 200 joules is used for both atrial fibrillation and atrial flutter. The operator needs to confirm that no one is touching the patient. and the monitor may be discharged by pushing an activation button. The button will have to be held in place as the monitor must sense the QRS complex to determine the proper time to deliver the shock. Generally, the patient will jump somewhat when the shock is delivered. Successful cardioversion is confirmed through observation of normal sinus rhythm on the cardiac monitor. The patient is observed in the emergency department until all signs of procedural sedation have cleared. Patients who remain in normal sinus rhythm can safely be discharged from the emergency department after an hour or so of observation. Most patients who are successfully cardioverted will remain in sinus rhythm and can be discharged home with no additional medications for follow-up with their cardiologist.
Okay, so as I was looking at the video, I saw in the chat there's some great questions, and I'm going to address those questions. The last video, as you see, shows how an elective cardioversion goes. This is very likely the procedure that J.J. Watt underwent. Again, the reports are that he underwent cardioversion, a shocking of his heart. So essentially what's done, you start an IV, you give some conscious sedation. When I've done these, I have an anesthesiologist, and yes, they'll use propofol. Many of you may remember that propofol was what was used with Michael Jackson, but that was in his bedroom, and that's not the appropriate place to use propofol. But in a medical unit where you have an anesthesiologist and all the emergency equipment you need to take care of a patient, something goes wrong, it's the ideal place for it. We've used it. I've used propofol when I was a fellow in the CCU many times, and it's a very effective medication and can be used safely in the proper setting with the proper backup. So once the patient's sedated, as you saw, there's a cardioversion. Now, notice he mentioned that you have the little synchronization, so you get those little spikes on the QRS. And with an elective cardioversion, when you shock, you want to make sure it doesn't shock on a certain part of the QRS, because you can put one in a life-threatening arrhythmia called ventricular fibrillation. So you don't want to do that. And so when this situation goes on, then you have a nice, happy, as we call it, happy cardioversion. Typically, the patient gets out in one shot, and after that, they are doing pretty well. You let them recover, wake up, and then everything's done. Now, I want to show you one other video where there's an emergent cardioversion. And they call it emergent. I should say urgent. It wasn't really emergent. Emergent cardioversion is not cardioversion. Emergent is when, well, you can have an emergent cardioversion if somebody's in an AFib and the blood pressure is very low. They can still be awake somewhat. The blood pressure is very low because it's compromised, and they're in cardiogenic shock or decompensating rapidly. So that could be emergent. But typically, when you're shocking someone in an emergency, it's not a cardioversion, but it's it's not a synchronized cardioversion, but either an conversion of ventricular fibrillation or something like that. But the supraventricular arrhythmias are usually urgent or elective. And the ventricular arrhythmias, when you're defibrillating someone as opposed to cardiovert them, is when they're in VFib arrest and you're doing CPR. I'm not going to show you that video, but here's an interesting video from an emergency room cardioversion. It's a few minutes, but I think it's worth looking at. And then once we come back from this video, I'm going to answer your questions, and we're going to talk about how we can wrap all this stuff up and give you some pointers in terms of A, how to prevent atrial fibrillation, and B, if you have atrial fibrillation, how to naturally reverse atrial fibrillation. So stay tuned. And as we get ready to go through this video, if you haven't done so, hit the thumbs up button, show us some love, and share this, and subscribe if you haven't had a chance to do so.
A lot of times it does, so we'll be.
As long as they're in the course of it,
Yeah, these are important educational tools. So we've tried. Charlie, what have we done so far?
I did 6 and 12 with adenosine. We did 24 along with vagal maneuvers here with no success.
No success. Okay.
All right, we're gonna send you back, okay? All right. Now this is gonna be a little uncomfortable, okay? That's the nice way to put it. The real way to put it is it's gonna feel like somebody hit you in the chest with a baseball bat. Okay? And hopefully we wanna have to do this for once. Alright.
Versed?
How are you
Got it
feeling?
already, or you need it, or Versed?
Just
right now.
I'll give you 30 seconds or so.
You might need some,
Oh,
that's
yeah.
impressive.
Put this back on you, okay?
Okay, so you need the Versed, or you got the Versed? Got it already, okay.
Yep, sorry. Put this on. Alright, Charlie. How are you feeling? I'll put this back on you here. Okay, start it up, thank you. Okay? Okay. Alright, here it comes, sir.
Trying to. Okay, bud. You're doing good, buddy.
You doing alright?
Keep working.
All right,
Okay.
all right.
Learn when a plan comes together, don't get Cardioversion.
He was kicking it 2 weeks, but he's better.
We didn't sedate him completely because of his low blood pressure.
Correct.
You doing okay, Mr.
Now
Bailey?
our heart rate's holding. Cycle that pressure again after it's done, please.
There you go. 1 over 66.
Mr. Glenn is doing good now.
You doing all right?
Yeah.
Yeah.
You okay?
How you feeling?
You can relax. You
Relax.
I know.
At
That's
least
that verse.
he's not gonna
Trying to
remember.
eat that pulse ox. Everybody likes to eat the pulse ox.
You're all right. You're all right, baby.
All right, Charlie. What else you want?
It's okay. You're doing good.
How you feel?
A little before and after. You doing okay? Good.
Relax back. It's okay.
Sorry about that, but problem's fixed, okay?
Now,
So make sure that he hasn't infarcted. You have to make sure that there's nothing.
His electrolytes.
Electrolyte abnormality. You gotta make sure he's not infected. You gotta make sure. I mean, I don't think he's withdrawing because it's been 3 weeks. He's not well, he was a little hyperdynamic. His heart rate, his blood pressure was fine. So
But
you
he
look
did
for
say
everything
he'd been
else.
having a little bit of hallucinations, and
what now?
he did say he had had some hallucinations and been like this for 4 days, so maybe his DT.
Yeah. So maybe.
He's
He
done
had
this-
next to where he was sitting a bucket about that full of vomit. Too.
Okay. Well, there you go. So you gotta work him up. You know, just search for everything. You know.
No, he's not.
And look for his guidance 1.8. I don't know what it's based on.
Well, I must have done one now.
I'm
Yeah.
sorry, but
And then see if he's in there. Look for the old stuff. Pour. Give him some fluids. I would give him some Ativan now. I would give him some multivitamins. I'll give him some diamonds for like. I'm not big on banana bags, but. And then just X-ray.
can you relax for just a minute? Put your arms down by your side.
Get one more EKG, honey.
But I think the back
You're doing
the back part
good.
now is
Can you
fine.
relax your arms?
That's pretty impressive heart rate.
So what we have here is a situation where a gentleman's in the emergency room and he comes in this arrhythmia, and it's really a supraventricular arrhythmia. And I was able to see the tracings during the arrhythmia. It looks like an atrial tachycardia. Now I'm not 100% certain, but if I can see it, and I froze it a little bit. And the reason I think it's atrial tachycardia is what we call a long RP tachycardia. That's 1. 2, they gave him adenosine in 6 milligrams and 12 milligrams. It didn't convert. You don't convert atrial tachycardia with adenosine because the circuit is isolated to the upper chamber. Adenosine works in the AV node area. And the facts of the long RP tachycardia could be an atypical AV nodal intervention tachycardia or AVRT or atrial tachycardia. Excuse the medical jargon. but I think that was an atrial attack. Plus, they pointed out this gentleman consumed alcohol regularly. Apparently, it recently stopped, but may have been in DTS. So, alcohol heart syndrome typically can cause atrial fibrillation or atrial attack. Other stressors include, steroids or ischemia, smoking. A lot of these things can trigger anything that can cause electrolyte imbalance. They were talking about magnesium imbalance, things like that, potassium, other oxidative stress, increased oxidative stress. Excuse me. Alcohol is an oxidative stress agent, bad food, processed sugars, etc. Some people ask some interesting questions. Somebody asked about the jab. I don't know necessarily if that has something to do. They have to come to our private channel and hear more about that. Let's see here. There was a question about, I wanted to take, they talk about the injection. Magnesium. Now, there's a great point about magnesium. What I want to say about magnesium is there are a lot of people who are magnesium deficient. And individuals have things like insomnia, headache, fatigue, anxiety, cardiac arrhythmias, can all be associated with magnesium deficiency. And when you check your blood level magnesium, it may be normal, but you still may have total body or tissue level magnesium that's abnormal. Magnesium is primarily an intracellular or a tissue-bound ion electrolyte. And it's really hard to just screen for magnesium deficiency. You have to have a high clinical suspicion. People who are on diuretics, or if you're drinking a lot of caffeine, that may have a diuretic effect. You may be deficient in magnesium. If you take drugs like proton pump inhibitors, they can reduce your magnesium absorption. Different peptides and things like that. Someone asked a great question: does aspirin help? Now, if you look at the old data of individual chronic atrial fibrillation where they did the warfarin trials, warfarin versus placebo was clearly a benefit of warfarin. So people with chronic atrial fibrillation with associated risk factors had a benefit with warfarin. If you looked at warfarin compared to aspirin, and now if you look at 81 milligrams of aspirin versus warfarin versus placebo, there was really no benefit with aspirin. There was one trial, however, when you used 325 milligrams of aspirin. So it was placebo, nothing, aspirin, 325 milligrams, and warfarin. Warfarin was significantly improved, better in terms of reducing stroke, but aspirin was better than placebo in that group. So there was at least one trial that showed some intermediate benefit of aspirin, even though it was inferior to warfarin. Hello, Pepper Goddess. How many times can a person have a cardioversion? That's a great question. I don't think there's an absolute upper limit. I've shocked individuals multiple times, certainly in an emergency situation, 10, 15. We've been in situations and, in defibrillator implants, we've had 40, 50 shocks. People get shocked 50, 60, 70 times with defibrillator. So there's not an upper limit. Granted, you get skin burn and things like that. But I've seen many shocks or cardioversions depending on the situation. There are a number of people ask about the COVID shot. I won't address that due to the YouTube algorithm. But if you, what you should do is go to our private channel where we talk about some of these things. So we, hold on one second here. On our private channel, we will cover a number of these things. I'm gonna give you MontgomeryHeart.com. I'm going to make a banner out of this. I'm going to put it in the chat. But you go there, sign up for our private channel. It really supports our research. It's a very modest cost per month. Join the inner circle. And the reason I suggest that is because We can talk about things. I can answer questions of this type without being scrutinized. So I'm going to share that with you on the banner. So go to montgomeryheart.com journey, and you can find out about, these kinds of questions that are very sensitive. It would be too sensitive to cover in this setting. So join our online community. Thank you, Jackie. We put the link there. Also, William, Mr. Bespoke Bibbs, I exercise 4 days a week, don't drink, smoke, or do so drugs, but have had a cardioversion twice and possibly a third. Yeah, it's possible to do a lot of the right things. And it could be some other things you need to do. Maybe check your magnesium level. You may need to be on a magnesium supplement. Make sure you check your diet and make sure it's an optimal, nutritionally optimal diet. But we work with a lot of people with atrial fibrillation. It can be a little bit tricky. But if you had the cardioversion that's keeping you out of sinus rhythm, then certainly that's a good thing. Keeping you in sinus rhythm, that's a good thing. So I think that's something that you should consider. But certainly look at your diet. Make sure you're not consuming alcohol to any extent. And be careful with the caffeinated beverages of any type can predispose you to atrial fibrillation. So all these things are very important. And these are all great questions. But J.J. Watt converted from atrial fibrillation. Godspeed to him, and hope things continue to go well with him for the season. He's a great athlete. He was a great asset when he was in the Houston community, and I'm sure he's a great asset to the community that he's in with the Arizona Cardinals. So Godspeed to him. That's all I have for you tonight. Thank you very much for joining us. And this has been a great show. Thank you for your participation. Spread the word. If you hadn't had a chance to, hit the like button. Always share this information. And if you hadn't had a chance to, please subscribe. But until next time, keep it fresh, natural, and live.